My name is Miles Day. I am the Trawick Racks Endowed Professor in Pain Research in the Department of Anesthesiology at Texas Tech University Health Science Center in Lubbock, Texas. I'm also the Pain Medicine Fellowship Director at Texas Tech, and I've assumed that role for the last 10 years. I'm also the Medical Director of the Pain Center at Grace Clinic. My background is in anesthesia. I trained at Texas Tech approximately 23 and a half years ago. I did my Pain Medicine Fellowship from 1997 to 1998 with Prithvi Raj and Gabor Rotz. And I have been at Texas Tech for the last 18 and a half years educating fellows and residents. And under my belt, I've got about 80 or so doctors that I've helped train over the years, and probably I'll double that by the time I retire. My topic today was spinal anatomy for the interventionalist, which is kind of right up my alley when it comes to education, because one of the things that I harp on, or I really emphasize to any trainee, whether a resident or a fellow, or practicing physicians who want to come back and learn more, is that anatomy is very, very important when it comes to doing procedures and diagnosing patients, because it will help you determine what sort of procedure you're going to do, or if you have an unfortunate complication, that you can figure out what may potentially have happened. Knowing the anatomy will make a procedure go more efficiently. It will hopefully allow better results. And also, if there happens to be an unfortunate complication, it will help the physician determine where the error may have occurred or what potentially would have happened. Educating doctors over the last 20 years, I really emphasize this because a lot of times I find that physicians are unprepared. They'll look at a fluoroscopic image and they can't correlate that with normal spinal anatomy, and so it takes them longer time to accomplish the procedure they want to do. When we're talking about anatomy, we'll kind of start from kind of the head to the toes. It's real important when you're visualizing radiographically to line up normal anatomical structures so you can recognize them. Starting with the cervical spine, the one thing that can be problematic for beginning physicians is lining up the end plates of the cervical spine. And this also can be applied to the thoracic and the lumbar spine. Physicians tend to forget the normal curvatures in our body, and so they tend to try to align everything normally regardless if they start at C2 versus C4 or C7. So they kind of get lost because they can't get a good picture. And for novices, this can be very frustrating because it makes them a little bit nervous, and it takes things longer to do. The second part of that is, after an AP, is getting a lateral view. And knowing the C-arm, which we should always use for our procedures, although some can be done with CT, is accommodating what we call parallax. Sometimes we'll get a lateral of the cervical spine, and all the anatomical structures are not lined up. So we need to take time to make sure we get those aligned, because then we will realize that our needle is in the right position, or because what we call parallax, it's not in the right position, and we need to adjust the C-arm so that our picture looks good. This will theoretically improve the efficacy of the procedure and decrease the number of complications, which is real important because we always want to do things safely. Now, when we get into the thoracic spine, it can be a little more problematic because of some of the pictures we get. The C-arm incorporates the lungs into our picture, and because of the different densities of the anatomical structures, we can't see things as well. So it's important for all of us to know that we need to utilize the functions of the C-arm to help us get better pictures. So moving from the thoracic region to the lumbar region, all the techniques that I've already spoken about need to be applied in this area as well. We need to remember the lumbar lordosis and the sacrokyphosis, because this, once again, will improve efficacy and decrease the number of complications. And everything I've always been taught by my mentors is you've got to do things safely. We have to accommodate for different patients. A lot of times doctors get frustrated when they get a little old lady who's got a scoliotic curvature and their initial pictures are not good, or they cannot determine the anatomy, and they somewhat give up. But if you apply the same principles regardless of the patient, you still can do procedure safely, and that's what we strive for.